Hello, doctors. How are you? Dr. Brony here. Please, if you can hear me, I want to know, because before we dive into it, I want to know if you can hear me. Just type yes, Dr. Brony, I can hear you. If you can hear me, please, just type yes, I can hear you. All right, please, if you can hear me, I want to know that you can hear me. So if you can hear me, just type yes. Awesome. Let's get going. I'm excited to spend this afternoon with you. As always, we're going to get into some very, very important discussion today, so we can break the sessions down. It's always a pleasure to see you on Sundays. It's always a pleasure. And thank you that we are all spending the time. So please make sure you send a link to your friends. Make sure that your friends are joining us. Please pick up your notebook. I'm trying to do some exercise to get some power in so we can get a ball rolling. So please get your friends into the class. Send it to every WhatsApp group you are in. Send it to every Telegram group, every Reddit group, every Facebook group. Send it to everybody. Let's get the ball rolling. So doctors, while you're also here, please, the channel is growing, the MedCognito brand is growing, and I want you to be part of it. So please, just click on subscribe to MedCognito YouTube right now. Subscribe, and give me a thumbs up as well, so that we can get this message to the entire world. We have people joining us from all over the world: India, Pakistan, Iran. It is my pleasure that we see as many international medical graduates and Canadian medical graduates cross the line into residency, practice-ready assessments. It's been awesome. So doctors, let's get the ball rolling. Today, we're going to get into approach to constipation. So that's exactly what we're going to do today. All right? So, but before that, remember that, at MedCognito, we also teach QE1. We teach NACOSKI. NACOSKI has just started. We did our first class in pediatrics. We did our last class in TDM for the exam in January, and we're going to start the preparation for the exam in May. So if you have any friend, or if yourself, you need to get into this exam, doctors, get in touch, and let's get it going. If you're also preparing for CAMS and, CV and MMI and, all those things, make sure that you send us a message on MedCognito and we'll get the ball rolling for you. All right. So today, I want you to know that if you are supposed to learn constipation, remember that constipation comes in two ways. According to the MCC objective, we have the pediatric constipation bit and we have the adult constipation bit. All right. So please, whenever you are learning, make sure that you are getting it right in that particular sense. So make sure that you divide your learning: pediatric constipation, adult constipation. Today, I want us to focus on adult constipation. All right. So if you go to the MCC objectives, let me get some water. If you go to the MCC objectives, you realize that they divide the constipation into adult constipation, pediatric constipation. And so today we are focusing on adult constipation, right? And adult constipation, the rationale for that particular objective says that constipation is common in adult patients and can be attributed to several possible functional and organic causes. It may have a significant effect on the quality of life and may be presenting feature of significant pathology. I have a question here, doctors. We have a tradition, and it looks like we are noting one word which goes through almost all the objectives. And the medical council used it as well in this rationale. Please, who can tell me, or who can type in the comment section, what is that one word which has made this very objective very important for us to consider so far as MCQ1 is concerned? Please type it in the comment section. Type it. While you are doing that, please don't forget to give us a thumbs up on YouTube. Don't forget to subscribe right away. Okay, today we need to get to 2,000 subscribers. We are at 1,640. So today, everybody needs to subscribe so that we can go. So please, what is that one word? One word. Beautiful. Dr. Titi Lopez says it's common. Dr. Mehu also says common. So doctors, you see, I always say this. the most important thing, Dr. Titilope, so you wrote common, so that is it, right? Remember something. Common things are common. Common things are common. Common things are common, right? Good. So now, the causal factors or the causal conditions. And remember that always the list is not exhaustive, but these are the most important things, okay? Diet and lifestyle. So we are looking at the causal conditions of constipation. Diet and lifestyle. Irritable bowel syndrome. Drugs. So today you must, before you go, you have to learn, okay, what are the drugs which can cause constipation? The commonest drug which you must know is opioids, right? Opioids can lead to constipation. And there must also be neurogenic causes of constipation. It can be central neurologic issues or peripheral neurologic issues. And we also have myopathic causes of constipation, as well as metabolic causes of constipation. I have a question. Who can give me an example of a metabolic cause of constipation? Metabolic. Just type the answer in the comment section. Metabolic cause of constipation. Metabolic causes of constipation. Who can give me an example of a metabolic cause of constipation? Okay. Beautiful. Dr. Asgar says, hypothyroidism. Beautiful. And so that is something you need to know, right? And then pregnancy, as well as obstructive lesions. So obstructive lesions like intestinal obstruction, right? Volvulus. All these things can lead to constipation. And then anorectal disease, because some people may have, anorectal cancer, anal fissure, hemorrhoids, and these can all be associated. Now, the key objective, giving an adult patient with constipation, all right, the candidate will diagnose the cause and severity and will initiate an appropriate management plan. Giving an adult patient with constipation, the candidate will diagnose the cause and severity and will initiate an appropriate management plan. That's the key objective. Now, the enabling objectives of the exam. Giving an adult patient with constipation, all right, the candidate will list and interpret critical clinical findings, including the features on the patient's history and physical exam that distinguish functional from organic causes. That is very important. So the first enabling objective is you've got to know the functional causes of constipation, and you've got to know the organic causes of constipation, and you must know from the history, the physical exam, what are the features which will cause you to say, this is a functional cause of constipation. What are the features which should also cause you to say, this is an organic cause of constipation, right? Number two, list and interpret critical investigations, including investigations required to determine whether the patient needs endoscopic examination or diagnostic imaging. So, in other words, this question is, or this objective is telling you that not everybody with constipation needs diagnostic imaging. Not everybody with constipation needs further evaluation. But in your exam preparation for QE1, you must know which patient will need endoscopy and who will not need endoscopy. If you have a patient who needs endoscopy and you don't request it, remember you are in trouble, right? And you also have a patient who does not need endoscopy and you request it, you are not really using the resources appropriately. All right? So that is something very important. Number three, construct an effective initial management plan, including one, putting in place a conservative plan of symptom management. So you have to ask yourself, of all the causes of constipation, which of them can you just reassure a patient and just treat symptomatically? And which of them should you actually give specific treatment for? And then outlining a plan for managing constipation that is secondary to medication. So remember that I told you that one of the causes of constipation as medications is opioids. So for example, if you have a patient who has been prescribed opioids, what can you do to prevent complications like constipation? There's a saying in medicine that the hand which writes the opioid must also write a stool softener, right? So whenever you're writing an opioid like hydromorphone, like hydromorphcontin, like morphine, like fentanyl patch, and the patient is going to use it for a very long time, you've got to make sure that you are also writing something so that the patient can be able to pass their stools easily. Some of the medications can be PEG, like lactulose, Senacort. All these are medications which can help the patient to pass stools easily. All right. And then, as part of your studies, you must also determine whether the patient requires specialized care or not. And number 4, you must be able to implement prevention strategies against constipation. So, doctors, with all these things we've just talked about, okay, now let's pick one topic and let's make sure we break that topic hand, foot, leg, we break it down systematically so that we can be able to use that to ace the exam. So, doctors, please, are we ready to roll? Please, if we are ready to roll, just type ready, ready, ready. We are ready to roll. If you are ready to roll, just type ready, because we're going to start with some questions and then we'll go and do some deep dive. So please, if you are ready to roll, let me know. I am ready. Dr. Bruni, I'm ready. I'm ready. Let's go. Let's go. Let's go. First question. You have a 35-year-old woman who presents to her primary care physician with a 6-month history of intermittent abdominal pain and altered bowel habits, including episodes of diarrhea alternating with constipation. She denies weight loss, blood in the stools, or nocturnal symptoms. Her medical history is notable for anxiety. Physical examination and laboratory tests, including complete blood count, are unremarkable. What is the next best step in management? A, refer to a gastroenterologist for further evaluation. B, recommend a gluten-free diet. C, reassure the patient and provide education about irritable bowel syndrome. D, test for fecal calprotectin to rule out inflammatory bowel disease. E, perform a colonoscopy to evaluate for colorectal cancer. Doctors, I've seen some answers coming. 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 So Dr. Khadija Iram says C. Okay. Let me see. Dr. Lydia is just enjoying herself and she's just laughing, right? And then Dr. Gamagi also says C. This one gave itself away because it's a very simple one. So the answer is reassure the patient and provide education about irritable bowel syndrome. This patient's clinical presentation is consistent with irritable bowel syndrome, right? And irritable bowel syndrome, you have to understand that it's a functional GI disorder, functional gastrointestinal disorder, which is characterized by chronic abdominal pain. So please take your time and write this down before we continue. What are the features of irritable bowel syndrome from this question? Number 1, it is a functional disorder. That's the first thing you need to write in your book. So please, doctors, I'm not moving on until you write it in your book. Write it. It's a functional GI disorder. Number 2, it causes chronic abdominal pain, right? Number 3, there's altered bowel habits. Number 4, there are no alarm features of irritable bowel syndrome. So if you have a patient who has chronic abdominal pain, who has altered bowel habits, and the patient has associated with weight loss, doctors, chances are that is not irritable bowel syndrome. Please, are you with me? Are you with me? I really want to know. Are you with me? If you are with me, let me know. Are you with me? If you have a patient who has chronic abdominal pain, altered bowel habits, and the patient has nocturnal symptoms, it happens in the evening, doctors, please, chances are that it is not irritable bowel syndrome. If you have a patient who has chronic abdominal pain, altered bowel habits, and there's blood in the stools, please be very careful. So, irritable bowel syndrome should not have weight loss. It should not have nocturnal symptoms. It should not have blood in the stools. And so in your exam, if you are thinking about irritable bowel syndrome and you see any of these alarm features, please run away. Run for your life, all right? Reassurance and education are key components of management of irritable bowel syndrome. And further diagnostic tests are not necessary at this stage. Okay, so now if you are sleeping and someone wakes you up, what are the features that make irritable bowel syndrome not likely? You must be able to tell them weight loss. You must be able to tell them nocturnal symptoms. You must be able to tell them blood in the stools, right? So why is referral to gastroenterologist wrong? Referral is unnecessary in the absence of alarm features or diagnostic uncertainty. So you don't need to refer because the patient did not have any alarm features. What about gluten-free diet? That's also incorrect because a gluten-free diet is not routinely recommended for IBS unless the patient has celiac disease, right? And what about testing for fetal calprotectin? So please, another learning point we've picked up here is that gluten-free diet is recommended for patients with celiac disease, right? And the third point, fecal calprotectin. This test is used to differentiate irritable bowel syndrome from inflammatory bowel disease, which is unlikely given the lack of systemic or alarm symptoms. So calprotectin, fecal calprotectin, as soon as you think about that, think about inflammatory bowel disease. As soon as you think about gluten-free diet, think about celiac disease, right? What about performing a colonoscopy? Routine colonoscopy is not indicated, right? Unless there are red flags. And so tonight, if you are sleeping and your friend wakes you up, hey, we are learning. Please wake up. Tell me the red flag features which will make irritable bowel syndrome not likely. You can be able to say weight loss, blood in the stools, nocturnal symptoms, and then you can go back to sleep, right? Because when you see those ones, you know there's trouble and you must investigate it further. Doctors, please, did the first question help? Did the first question help? And then with the learning points, did it really help? If it did, please let me know so we can move on. The first question we just did. We have 5 more questions before we do a deep dive, and then 5 more questions, then deep dive, 5 questions, deep dive. So today is going to be a long day, right? Please, did it make sense? Beautiful, beautiful. Let's go to the next one. A 28-year-old man reports frequent abdominal pain and diarrhea for the past year, which worsens during stressful situations. He denies significant weight loss, blood in the stools, or nocturnal symptoms. He has a history of gastroesophageal reflux disease and fibromyalgia. Which of the following is most strongly associated with his likely diagnosis? So now we are looking at associations. A, elevated fecal calprotectin. B, psychiatric comorbidities such as anxiety and depression. C, positive antitissue glutaminase antibodies. D, evidence of small intestinal bacterial overgrowth on breath testing. And D, colonoscopic findings of erythema and ulcerations. Which of the following is most strongly associated with his likely diagnosis? Which of the following is most strongly associated with his likely diagnosis? Are you going for A? Are you going for B? Are you going for C? Are you going for D? Doctors, it looks like Dr. Aaron Smith took the lead and he went for B. Dr. Titi Lope also went for B. Dr. Jagdeep, beautiful, went for B. Fearless, a doctor is called Fearless Muntu, also went for B. So now we are learning associations. The first question helped us to identify red flag symptoms. Now we are learning associations. You realize that psychiatric comorbidities such as anxiety and depression are strongly associated with irritable bowel syndrome, right? So you have to understand something, that irritable bowel syndrome is strongly associated with psychiatric conditions such as anxiety, depression, and somatization, all right? And this patient symptom pattern and stress-related flares are characteristics of irritable bowel syndrome. Now, with fetal calprotectin, we already talked about it. It points more to inflammatory bowel disease. Positive antitissue glutaminase antibodies. Please write this down. Usually, that is positive in celiac disease, not irritable bowel syndrome, right? So two things we've learned in celiac disease today. Gluten-free diet is recommended. Number 2, positive antitissue transglutaminase antibodies. Please, doctors, write this down. Celiac disease. What are the two things we are learning today? Positive antitissue glutaminase antibodies and gluten-free diet. Give gluten-free diet. All right? What about choice D? Evidence of small intestinal bacterial overgrowth. That's also incorrect, right? Because small intestinal bacterial overgrowth can mimic irritable bowel syndrome, but it is not a diagnostic criterion or strongly associated with irritable bowel syndrome. And colonoscopic findings of erythema and ulcerations, it does not also cause mucosal changes. Remember that irritable bowel syndrome does not cause mucosal changes, okay? So all those are wrong. So what are we learning today? Psychiatric comorbidities are associated with irritable bowel syndrome. And those psychiatric comorbidities, examples of them can be anxiety, example can be depression, an example can be somatization. As well, when we are looking at celiac disease, if someone has celiac disease, gluten-free diet, gluten-free diet, gluten-free diet, and it is positive for anti-tissue glutaminase antibodies. Doctors, please, are we all on the same page? Can we move on to the next question, please? If we can, type yes, yes, yes. Let me know so we can move on. If we can move on to the next question, just type yes and let's go. Just type yes and let's go. Type yes and let's go. All right? Good. Next question. Remember, we are only solving questions. We've not started the class yet, right? We're only solving questions. So you have a 45-year-old woman with a history of chronic fatigue syndrome and functional dyspepsia who presents with intermittent bloating, abdominal pain, and constipation for the past year. She has tried fiber supplements without improvement. Physical examination is unremarkable, which of the following most strongly supports a diagnosis of irritable bowel syndrome? A, age over 50 years with new onset symptoms. B, alternating bowel habits without nocturnal symptoms. C, history of significant unintentional weight loss. D, positive family history of colorectal cancer. E, elevated CRP and anemia on laboratory testing. Which of the following most strongly supports a diagnosis of irritable bowel syndrome? And we have options A, B, C, D, E. Let me drink some water. Beautiful. So what's the answer? So the answer is alternating bowel habits without nocturnal symptoms. Remember that we talked about the red flag signs of irritable bowel syndrome: weight loss, blood in the stools, nocturnal symptoms. If you see any of these in a patient with alternating bowel habits, likely it is not irritable bowel syndrome. Likely something sinister is happening. So irritable bowel syndrome often presents with altered bowel habits, constipation, diarrhea, or both. Okay, and there's absence of alarm features such as nocturnal symptoms, weight loss, or systemic signs of the disease. Now, if you have a patient who is over 50 years and now this patient is presenting with these new onset symptoms, doctors, be careful. Chances are that that is not irritable bowel syndrome. Chances are that something more serious is happening, right? Weight loss is also a red flag. Family history of colorectal cancer in a patient with alternating bowel habits. Don't just go saying, oh, Dr. Bonito has irritable bowel syndrome, therefore this patient has irritable bowel syndrome. No. And elevated CRP and anemia, no. So if you have a patient who is more than 50 years with new onset bowel habits changes, or significant weight loss, or family history of colorectal cancer, or elevated CRP and anemia, doctors, run away from irritable bowel syndrome. Run away. All right? Good. Next question. So 32-year-old woman reports chronic diarrhea and abdominal pain exacerbated by stress. She has a history of major depression and gastroesophageal reflux disease. What's the most appropriate initial diagnostic test to confirm the suspected diagnosis? A, colonoscopy with biopsy. B, fecal occult blood testing. C, serum tissue glutaminase antibody. D, symptom-based clinical diagnosis. E, small bowel imaging. What's the correct answer? What's the correct answer? What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? Doctors, you guys are killing it. Ifya Yeboah, awesome. You know, Dr. Ifya Yeboah, beautiful. Dr. Irene, beautiful. Dr. Sabine, awesome. So everyone is going for D. It looks like we've gotten the concept right. Symptom-based clinical diagnosis. In irritable bowel syndrome, it's a clinical diagnosis based on the symptoms. And the symptoms are what we call the Rome criteria, Rome 4 criteria. Colonoscopy or biopsy, we don't use that to diagnose irritable bowel syndrome. Fecal occult blood testing should be negative in irritable bowel syndrome. We don't use that. Serum tissue glutaminase antibody is used for celiac disease. Small bowel imaging, you're thinking about other things apart from irritable bowel syndrome. So doctors, we are using this topic and we are going into other things, So today we've talked about celiac disease. We've talked about how to make the diagnosis. We've talked about, the food the patient should be taking if they have been diagnosed with celiac disease. We've talked about even inflammatory bowel disease as well and what to do. We've talked about red flag symptoms which should push us away from irritable bowel syndrome. Always remember, irritable bowel syndrome is symptom-based clinical diagnosis. Last question before we do a deep dive into the introduction. Introduction. We've not started the game yet. So please make sure you get some orange juice and some water because we're going to go into deep so far as irritable bowel syndrome is concerned. So doctors, a 50-year-old man presents with bloating, abdominal pain, and diarrhea for several months. He has a history of anxiety and fibromyalgia. BMI is 22 kilograms per meter squared, and his physical exam is unremarkable. Was the most accurate statement regarding his likely condition? A, irritable bowel syndrome is more common in males than females. B, irritable bowel syndrome prevalence decreases after 50 years. C, irritable bowel syndrome requires colonoscopy for diagnosis. D, irritable bowel syndrome is associated with significant weight loss. And E, irritable bowel syndrome prevalence is unaffected by geographic location. What's the correct answer? Some of the doctors are breaking my heart. Dr. Doji says E. Beautiful Paris says E. Dr. Paramita also says E. Dr. Ronnie Lankela says B. Doctors, read the question well. What is the most accurate statement regarding his likely condition? This patient obviously may have irritable bowel syndrome. What's the most accurate statement? Please think about it again. What's the most accurate statement? Let's start one by one. When you take males and females, which people or which group is irritable bowel syndrome more common in? Is it males or females? Please type, let me see. Is it males or females? Type. We are going through the answers one by one. Males or females? Is it males or females? Beautiful. So almost everybody is saying females. Okay, so that means A is wrong, right? A is wrong. Okay, let's go to the next one. Irritable bowel syndrome. Remember what I said about 50-year-olds. Is it likely that you are going to see irritable bowel syndrome in patients above 50 or patients below 50? Doctors, please. Is it likely that you will see irritable bowel syndrome in patients above 50 or patients below 50? Now people are saying, oops. Paris, beautiful Paris says, oops. And I like that. Beautiful. So if I tell you that irritable bowel syndrome prevalence decreases after 50, is it a true statement or a wrong statement? So B, is B a true statement or a false statement? Please, I want to know. Tell me the answer. Is B a true statement or a wrong statement? Beautiful. So B is a true statement. So we've seen that A is false, so A is wrong. But we've seen that B is true, so B may be correct, or B is correct. Okay, let's go to C. Irritable bowel syndrome requires colonoscopy for diagnosis. Is it a true statement or a wrong statement? Let's talk about C. Is C true or false? Doctors, is C true or false? Beautiful. So C is also false, right? Okay. Now, D, irritable bowel syndrome is associated with significant weight loss. Is it true or false? That's also false, right? And then E, irritable bowel syndrome prevalence is unaffected by geographical location. Well, many people may not know this one, right? But likely, so what is the true statement in all that we've done? What's the truest statement in all that we've done? What's the true statement in all the options? Is it A? Is it B? Is it C? Is it D? Or is it E? What's the true statement here? Beautiful. So, Dr. Khadija, now the answer is B, right? So, IBS prevalence decreases after age 50. IBS is less common in individuals who are over 50 years of age. And the condition is more prevalent in younger people and females, right? So I think this is correct, right? Got it right. So Dr. Ronnie, yes. Dr. Ronnie Lankela, you got it right. When everybody was going for D, Dr. Ronnie went for B. So that is beautiful, right? So geographic variation exists as shown in prevalence studies so far as IBS is concerned. So doctors, please, this is just questions about introduction. Please, how was the class? How was it? How was it? Let me know. How was it? Because we are now going to go into the introduction itself. I'm going to give a lecture. Tell me, how was it? The 5 questions we did. How was it? How was it? Did you like it? Did you not like it? Let me know. How was it? Beautiful, beautiful, beautiful. So Dr. Sabine says, amazing, amazing. Dr. Khadija says, great, beautiful. So if you're saying it's great, please subscribe to the YouTube channel right now. Subscribe right now, please. Subscribe and give us a thumbs up. Give us some love. Yay. Okay. So we're going to do a deep dive into irritable bowel syndrome right now. Okay, please subscribe and give us some love on YouTube and on Facebook. Dr. Shaza is asking, are these questions according to the new MCQ1 pattern? Of course, because we are focused on the MCQ1 objective and we are breaking it down. Okay, that's all we are doing. We are focusing on the MCQ1 objective and we are breaking it down. So let's move on. What is irritable bowel syndrome? Remember that I've said it in the past, but it's a functional GI disorder. Okay, functional. Remember that. And it is characterized by chronic abdominal pain with altered bowel habits. That's something you have to know. So there can be diarrhea variant, there can be constipation variant, or there can be both. There can be diarrhea and constipation at the same time. Okay? One key fact you need to know is that only a small percentage of affected individuals will seek medical care. And 40% of patients with irritable bowel syndrome usually lack a formal diagnosis. So please remember that. Functional GI disorder, chronic abdominal pain, altered bowel habits, diarrhea, constipation, or they may have both. Now, remember that MCQE1 can draw so many links. So I was looking at irritable bowel syndrome and public health. What is it? Irritable bowel syndrome increases healthcare burden. What do I mean by that? There's increased healthcare costs. That's one thing you have to know. Number 2, it is the second highest cause of work absenteeism in the first world. That's in Canada, in US, second highest cause of work absenteeism. So why do people not go to work? Most of the time, the second highest cause is irritable bowel syndrome. It also accounts for a high percentage of referrals to gastroenterologists. So if you are preparing for the QE1, that's what I put in the yellow highlighted point. You must be able to link irritable bowel syndrome to work productivity and healthcare economics, right? That's irritable bowel. So this is the link between irritable bowel syndrome and public health, right? Now, when I'm teaching and I put this guy with the light bulb, right? That is something you need to keep in mind. So if you want to take a screenshot, that's fine. I don't mind. If you want to share this with your friends, that's fine. I don't mind. Remember that the prevalence of irritable bowel syndrome decreases in individuals more than 50 years. It decreases. Number 2, it is higher in females as compared to males. So about 14% in females, 9% in males. So how do you remember this? How do you remember this? Irritable bowel syndrome loves younger females. Always do that. Remember that, right? If you keep that in mind, it will help you to remember very well. And the memory aid is this. Please write this down. I don't want to run. So if you remember IBS, irritable bowel syndrome, always think about irritable, busy young people, and stressed young people. Younger, active individuals. So if you think about IBS, irritable bowel syndrome, think about irritable, busy, and stressed, right? Irritable, busy, and stressed. IBS, irritable, busy, and stressed. Irritable, busy, and stressed. Okay, good. So another memory aid. If you think about, remember that I said there's the diarrhea type or the diarrhea predominant, the constipation predominant, the mixed type. Now, if you think about the constipation predominant one, because we are dealing with MCQs, always remember that the constipation predominant IBS is more common in females. Okay, first we learned that the prevalence decreases as people grow above 50. Number two, more common in females, right? And then especially the constipation predominant one, it is more common in females as well. Okay, doctors, please, the information I've given so far, can we move on? I want to make sure, can we move on? If you can't move on, let me know. And if I should go back, let me know. If I can move on as well, let me know. I want to make sure that we're getting it right. Should I move on? 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 Okay. So it looks like you professors want me to move on. So let's move on then. Now, this is something very important you also need to know, because the objective was highlighting on it, right? Conditions associated with irritable bowel syndrome. Conditions which are associated with irritable bowel syndrome. Number one, fibromyalgia. Number two, chronic fatigue syndrome, also known as systemic exertion intolerance disease. Number three, gastroesophageal reflux disease, GERD. GERD. These are conditions associated with irritable bowel syndrome. Number four, functional dyspepsia. Number four, functional dyspepsia. Number five, non-cardiac chest pain. Non-cardiac chest pain. By the way, doctors, usually when I'm done with a class, many people want to get in touch with me. So if you want to, my number is scrolling at the bottom of the page. I'll prefer that you send me a WhatsApp message so that I can communicate to you wherever you are. Okay, so +1 306 891 5649 +1 306 891 5649. So you can start sending your WhatsApp messages. Don't call right now because I'm teaching, but send your WhatsApp messages so that as soon as I'm done, I can attend to you. All right, because after that, it looks like a lot of people want to talk to me, but if you can start sending your messages, and I can start responding right away. Okay, so let's continue. Conditions which are associated with irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, gastroesophageal reflux disease, functional dyspepsia, non-cardiac chest pain, okay? And there's some psychiatric conditions as well, major depression, anxiety, somatization. Remember these very well. Major depression, anxiety, somatization. I'll continue. So always remember that irritable bowel syndrome is part of a spectrum of functional and psychosocial disorders. And the high yield tip for the MCQE1 is that if a patient has irritable bowel syndrome, what you also need to do is to check for coexisting conditions. We've already talked about some of them. So examples again, fibromyalgia, depression, right? So as soon as you see irritable bowel syndrome, number one, second cause of absenteeism in the first world. Number two, females are more affected. Number three, prevalence decreases as people grow beyond 50. You know, it is associated with other psychiatric and other conditions like fibromyalgia, chronic fatigue syndrome, functional dyspepsia, somatization, you know, anxiety, depression, right? So as soon as you hear irritable bowel syndrome, start looking for other clues. Does this patient have depression? Does this patient have anxiety? Does this patient have somatization? Right? So, doctors, we are going to get into another set of questions. The review we just did, is it okay? Is it okay for you? The review we just did, is it okay for you? I'm going to get into another set of questions. The review we just did. If you are asleep and someone wakes you up, Hey, you said you attended Dr. Ronnie's class at MedCognito. Can you give me a review of what he did? Can you do that? Please, can I do that? Can I move on? Hello? Can I move on? Beautiful. Dr. Ibironke says I can move on. Therefore, I'm moving on. Okay? Next set of questions. A 32-year-old woman presents with 6-month history of cramping abdominal pain, which occurs several times a week. She reports that the pain is relieved after defecation, often associated with bloating and flatulence. Her bowel movements alternate between loose stools and constipation. Physical exam is unremarkable, and initial blood tests, including complete blood count and C-reactive protein, are normal. What is the most appropriate next step in management? A. Perform colonoscopy to rule out inflammatory bowel disease. B. Initiate a gluten-free diet for presumed celiac disease. C. Diagnose irritable bowel syndrome using symptom-based criteria. D. Order stool studies to evaluate for parasitic infections. And E. Prescribe an antibiotic for possible bacterial overgrowth. This one looks very simple because we are talking about irritable bowel syndrome. We've already talked about the fact that we use symptom-based criteria. So that is the answer. C is the answer, right? I'm not going to belabor the point. Let's move on to the next point. You have a 28-year-old man who presents with a year-long history of intermittent diarrhea and abdominal pain that occurs several mornings per week. He describes the diarrhea as loose, small in volume, and often accompanied by mucus. He denies nocturnal symptoms, rectal bleeding, or significant weight loss. What feature in this patient's history most supports a diagnosis of irritable bowel syndrome? A. The presence of mucus in the stool. B. The absence of nocturnal diarrhea. C. Recurrent nature of the symptoms. D. The relationship of pain with defecation. And E. The presence of abdominal bloating. What feature in this patient's history most supports? So there may be features which supports irritable bowel syndrome, but what is the topmost feature of irritable bowel syndrome in this patient? Doctors, please share the link with your friends. Share the link with your friends. In WhatsApp, in Facebook groups, in YouTube, in Telegram, everywhere. Share the link with somebody. Okay, and then those who want to reach out to me, please. People have already started reaching out. So in order for me to be able to attend to you, +1 306 891 5649. +1 306 891 5649. Now let's go back to the question. What feature in the patient's history most, that's the word you want to operate it, most supports the diagnosis of irritable bowel syndrome? And the correct answer is D, the relationship of pain with defecation. You realize that a key feature of irritable bowel syndrome is abdominal pain related to defecation as defined by the Room 4 criteria. Okay? So this history strongly suggests irritable bowel syndrome in the absence of alarm features. And so in the next deep dive, what we'll be doing is we'll be going into the Room 4 criteria and learning a lot. Why is A incorrect? Mucus in the stools. It is common, but not specific to irritable bowel syndrome. What about B? The absence of nocturnal diarrhea helps to rule out inflammatory bowel disease or malabsorption, but it is not diagnostic of irritable bowel syndrome, right? Why is C incorrect? Recurrent symptoms. They are part of irritable bowel syndrome, but they are not specific and can occur in other conditions. And why is E incorrect? E is incorrect because abdominal bloating is a common but non-specific symptom of irritable bowel syndrome. Doctors, thank you. The numbers are increasing. Now we are at 151 participants live. This is powerful. This is powerful. This is revolutionary. Please keep sharing the link. Keep sharing the link. Keep sharing the link so that your friends can join us, okay? And please don't forget to subscribe to our YouTube channel so that we can grow with you. Okay. Next question. You have a 45-year-old woman who presents with abdominal pain, diarrhea, and bloating. She reports 10 months of recurrent symptoms, which are often triggered by meals and relieved after defecation. She denies weight loss, blood in the stools, or fever. Physical exam and routine laboratory tests are normal. Which feature in this patient's history would prompt further investigation rather than diagnosis of irritable bowel syndrome? A, symptom onset following bacterial gastroenteritis. B, worsening symptoms after stressful events. C, alternating diarrhea and constipation. D, nocturnal diarrhea. E, a sensation of incomplete evacuation. Which of these will cause you to do further investigation and not just say this is just irritable bowel syndrome? So the answer is very simple, and the answer is D, nocturnal diarrhea, because we learned that the red flags which should cause you to think about something different apart from irritable bowel syndrome are fever, night sweats, weight loss, nocturnal diarrhea, blood in the stools, strong family history of colorectal cancer, right? Okay. And then even a patient who is more than 50 years with new onset of alternating bowel habits, that becomes concerning. Next question. 35-year-old man presents a 6-month history of loose stools and abdominal discomfort. He denies rectal bleeding, weight loss, and nocturnal diarrhea. Physical exam is normal. He was recently started on high fiber diet, which has worsened his bloating and diarrhea. What's the most appropriate dietary recommendation for this patient? A, continue the high fiber diet to improve symptoms over time. B, reduce dietary fiber intake, particularly insoluble fiber. C, avoid lactose containing foods entirely. D, initiate a gluten-free diet. And E, start a low residue diet. Low residue diet is E. D, initiate gluten-free diet. C, avoid lactose containing foods. B, reduce dietary fiber intake. And then A, continue high fiber diet to improve symptoms over time. What's the correct answer? The correct answer is B, reduce the dietary fiber intake, particularly insoluble fiber, because in patients with irritable bowel syndrome, insoluble fiber can exacerbate bloating and diarrhea, okay? And a diet modification focusing on soluble fiber may improve their symptoms. So, lactose avoidance is not correct. Continuing the high fiber diet is not correct. Gluten-free diet we've noted is not correct, because that is good for celiac disease, and a low residue diet is not typically recommended in irritable bowel syndrome. So, doctors, before we go on to the next set of questions, I want you to know that we had our first med drill on January 8th. We're going to go more deeper into irritable bowel syndrome, but I want you to know this. We had our first med drilling on January 8th, and med drill is basically like me coming in and lining the doctors up and, drilling them. Usually med drills is focused on the weaknesses of the students, right? So they said that in January, they want us to do drills in ethics. So January 8th, we did our first med drill. So I asked them, hey, share your candid opinion. How was the class? Someone said it was very insightful. Another doctor said, I learned and unlearned a lot of things. It was awesome, but my head right now, boom! That's the med drill for you, because the med drill is fast-paced, quick revision, that kind of thing. And it's basically to prepare candidates for the D-Day, the exam. Other people say it was very much informative, well done, it was awesome, I loved it, Others said it was fire. And so, doctors, med drills are prepared for everybody, whether you are a med cognito candidate or you're not a med cognito candidate, right? Med drills are there for you. Med drills, what is med drills? It is 6 hours of top-up class for our students, and it is free for med cognito students. Now, why do we do med drills? So the candidates, as they are studying, may say, Dr. Bruni, I think I have some weaknesses in ethics, or I think I have some weaknesses in psychiatry. So I want you to come in and review all the concepts with me. So on January 8th, we did 3 hours. On January 20th, we'll do another 3 hours of ethics again. This is my special time with our students, right? And even those who are not our students also attended. I remember some names, but I don't want to mention them, right? They attended the class. It was awesome. So doctors, I want to just let you know that the January 8th is done, but you can watch the replay. And we have January 20th as well. We're going to do another med drill for ethics. And we're going to smash it again. So please, doctors, you may be in Med Cognito, you may not be in Med Cognito. You are invited to join us. For those in Med Cognito, it is free. Very free. You don't need to worry yourself. You get access to it, the replay to be loaded in your portal, right? And we have some live lecture recordings. Everything is free for you. It's there. For those who are not Med Cognito students, you will have to pay. And it's a very small token for the 6 hours you are spending with us. You will not get a replay, and you will not get our proctored mocks. You will not get anything apart from that class. So doctors, I just want you to know, whether you are a Med Cognito student or you are not a Med Cognito student, take advantage. Come for the med drill on January 20th. If you want to register, you can scan the QR code right now, okay? Or what I will do is I will drop the link in the portal for you so that you can use that to register, okay? If you want to attend the med drill, let me know. I will send a link to you right now. But I think the advantage is just even go for a 1-month package with Med Cognito so you can get access to everything. You can get access to all the 8 classes we will do that particular time. You'll get access to the mock exams. You get access to time with me. You get access to everything in Med Cognito. But your guess is as good as mine. If you want to just do med drills, that is fine. If you also want to come in for everything Med Cognito has to offer, that is also fine. All right? So that's med drills for you. Now, apart from the med drills, the candidates also had nephrology class, and nephrology is something a lot of candidates struggle with. And someone said, that was a long but very good class. Thank you, sir. Thank you, Med Cognito. Another one said, the class was incredible. One of the best nephrology classes I've attended. Thank you, doctor. Another one said, extremely helpful class today, nephrology. Another doctor said, and this doctor is in Pakistan, by the way. She's currently in Pakistan. She said, I would like to sincerely appreciate the facilitator of our class today. He was extremely helpful, patient, and attentive to all the students' queries. Highly recommendable, right? And then another class, one said, the nephrology class was very insightful and detailed with well-articulated notes after the questions. Thank you, doctors. So true. I joined late, but I gained a lot. So, doctors, that is it. Tonight, there is an obstetrics class as well. So after this class, we're going to go into obstetrics tonight. So those in Med Cognito, you better get some orange juice. Orange juice. So Dr. Amna is asking, 1 month registration will give us access to everything. Yes, you get access to everything. Everything. The mocks in the portal, everything. Every video Med Cognito has for you to study, you get it. Even for 1 month. Okay, 1 month access is just $450. You get everything, right? So now let's do a deep dive into clinical manifestations of IBS. I hope this announcement helped. Okay, good. So I'm going to give you some features. And the first feature I want to talk about is chronic abdominal pain. Chronic abdominal pain, okay? Chronic abdominal pain. So the chronic abdominal pain comes with cramping, with variable intensity and periodic exacerbations. And pain is often related to defecation. So remember that. The patient will have some chronic abdominal pain, and the pain is often associated with defecation. And it may be relieved or worsened by defecation. Now, doctor, some of you are asking some questions. What I'll say is, just send me a WhatsApp right now on +1 306 891 5649 +1 306 891 5649, so that when I'm done with the class, I myself will respond to all those questions, okay? Because I see that Dr. Sabiha is asking a question, and then Dr. Amna is also asking a question. So just send me a WhatsApp right now. I'll call you after the class. So there's chronic abdominal pain, and it is related to defecation. It may be relieved or worsened by defecation. So the abdominal pain of irritable bowel syndrome, it can be relieved or worsened by defecation, right? So never get confused. And it is triggered by emotional stress and meals, okay? and there's associated abdominal bloating, and there's increased gas production. So they pass a lot of gas and they belch a lot. So doctors, please write these down. Write these down so I don't forget them. Chronic abdominal pain with irritable bowel syndrome associated with defecation, relieved or worsened by defecation. Emotional stress and meals can worsen it or trigger it. There's abdominal bloating, and the patient may have flatulence or belching. Okay? What's the next thing I want to talk about? So, the high yield buzzwords for irritable bowel syndrome in relation to the pain. Think about pain plus stress plus meals. That's what I call the IBS trigger triad. Pain, abdominal pain, plus stress, plus meals. Think about the IBS trigger triad. I've always told you, when you see this gentleman with a light bulb in my notes, know that that is a high yield buzzword I want you to know. Okay? Good. The second feature I want you to know about is altered bowel habits. And the features can be diarrhea, constipation, alternating diarrhea and constipation. And the patient may also have normal bowel habits alternating with the symptoms. So remember, irritable bowel syndrome. Not everybody with irritable bowel syndrome has diarrhea. Not everybody with irritable bowel syndrome has constipation. Some may have diarrhea alone. Some may have constipation alone. Some may have diarrhea and constipation. Some may even have normal bowel habits which alternates with the symptoms of abdominal pain, which is worse or relieved with defecation, right? And then the diarrhea in irritable bowel syndrome. Usually it is frequent, loose stools of small to moderate volume, okay? And it occurs during the waking hours. That's why I'm saying that if the patient is having nocturnal symptoms, that's a red flag. That's a red flag. That's a red flag. And the diarrhea is usually preceded by lower abdominal cramping, urgency, okay, and sensation of incomplete evacuation. Most of the time, about half of patients with irritable bowel syndrome will report mucus in their stools. So that's also something you want to pay attention to, right? They can report of mucus in their stools. Now, one thing you need to know about the irritable bowel syndrome diarrhea, remember all the things we said about it. But if you have a patient and you are being told that the patient produces large volume diarrhea, be very careful. Diarrhea with blood, be very careful. Nocturnal diarrhea, be very careful. And greasy stools, be very careful. So please write in your notebook right now, what are the features of diarrhea which do not point to irritable bowel syndrome? Large volume diarrhea, bloody stools, nocturnal diarrhea, and greasy stools. These are the features. So in your MCQs, you should not be beaten by any of these. If you have a patient with large volume diarrhea and you are thinking irritable bowel syndrome is one of the diagnoses, run away from that. Bloody diarrhea, you're thinking of irritable bowel syndrome is one of the diagnoses, run away. Nocturnal diarrhea, irritable bowel syndrome, run away. Greasy stools, run away. It does not usually occur in the night. Usually the diarrhea occurs during the waking hours of the patient's life. Doctors, please, are we okay? Before I move on, I want to know, are my students getting it? If you're not getting it, I'm ready to go back. Please, are you okay? Are you okay? If you're not getting it, I'm going to go back. So can I move on? We've looked at the features of abdominal pain in irritable bowel syndrome. We are now looking at the features of diarrhea in irritable bowel syndrome. Can I move on? Okay, good. Okay, thank you. Now let's look at the constipation. The constipation in irritable bowel syndrome, the features are that the stools are hard and they are pellet shaped. And they usually have a sense of incomplete evacuation, even when they have an empty rectum. So stools are hard, pellet shaped, consistent and persistent sensation of incomplete evacuation, even with an empty rectum. Okay, good. So the memory aid, irritable bowel syndrome, They have morning urgency with mucus. Remember that we've said about 50% of patients with irritable bowel syndrome will have mucus in their stools. The constipation type of irritable bowel syndrome, they have pellet stools and empty effort. So even when they have pooped, they still feel that there's something there, right? So that is it. Now, how are we going to diagnose irritable bowel syndrome? Irritable bowel syndrome is suspected in patients with chronic abdominal pain, altered bowel habits. We use the symptom-based criteria, and there's limited testing. We've already talked about that, right? What's the diagnostic criteria? So now that we've looked at all the features, now let's look at the diagnostic criteria of irritable bowel syndrome. We use the room 4, 4. 1, 2, 3, 4. Room 4, 1, 2, 3, 4. Room 4, 1, 2, 3, 4. Room 4 criteria, okay? The patient will have recurrent abdominal pain on average more than 1 a day per week in the last 3 months. And there's association with more than or equal to 2 of the following. So, recurrent abdominal pain. We said that the abdominal pain can be made worse or improved with defecation, right? Recurrent abdominal pain, more than or equal to 1 time a week in the last 3 months, associated with more than or equal to 2 of the following. A, defecation. B, change in stool frequency. C, change in the form of the stool, the appearance of the stool. So there's a change in the form of the appearance, there's a change in the frequency of the stool, and it is related with defecation. So the abdominal pain may be improved or worsened with defecation. That is how we make our diagnosis of irritable bowel syndrome with the room 4 criteria. Now, the stool types that I talked about, we have something we call the Bristol Stool Form Scale. When you are done, just Google it. It will give you the various types of stools which can occur in irritable bowel syndrome. But remember that there are 4 types. Number 1, we have predominantly constipation. By the way, I said something about the constipation type. Which group is it more common in, males or females? The constipation predominant irritable bowel syndrome. Which group is it more common in? Is it in males or females? Please answer me. Is it in males or females? The constipation predominant one. Is it in males or females? We talked about that when the class started. Is it in males or females? Beautiful, beautiful, beautiful. So constipation type is more common in females. And then we have the predominantly diarrhea type. And then we have the mixed type where the patient has constipation and diarrhea, mixed. And then we also have the unclassified type, which does not fit into any of the subtypes. So we have CDMU, constipation predominant, diarrhea predominant, mixed bowel habits, and unclassified. And so I bring my friend back again. CDMU, constipation, diarrhea, mixed, unclassified, right? So if you want to remember the stool types in IBS, constipation type, diarrheal type, mixed type, and unclassified type. And the room 4 criteria is the gold standard for diagnosing it. Okay, so now if you are sleeping and I wake you up, tell me about the room 4 criteria. You should be able to do that, right? Okay, so doctors, are you ready for some questions, please? Are you ready for some questions? Are you ready for some questions, please? Let me know. Let me know. Are you ready for some questions, right? Are you ready? Are you ready? Are you ready for some questions? If you're ready, let's go. Okay, first one. 45-year-old woman presents with a 1-year history of intermittent abdominal pain, bloating, and diarrhea. Symptoms are worse after meals and sometimes improve after defecation. She denies weight loss, rectal bleeding, or nocturnal diarrhea. Physical exam is unremarkable and initial laboratory testing, including complete blood count and C-reactive protein, is normal. What's the next best step in the management? What's the next best step in the management? A, perform colonoscopy with biopsy to evaluate for microscopic colitis. B, diagnose IBS and initiate dietary modification. C, test stool for fecal calprotectin. D, perform serologic testing for celiac disease. And E, start a high fiber diet. This one should be very easy. The answer is B, with all that we've learned, right? With all that we learned. We're not going to do a colonoscopy because we are not thinking about inflammatory bowel disease or colon cancer. We're not going to do fecal calprotectin because that's is suggestive of, inflammatory bowel disease. We're not going to do celiac testing because celiac testing totally different. We're not going to do a high fiber diet, which may exacerbate the symptoms. So that is it. Next question. So this one we are running through it. 34-year-old man presents with 8 months history of chronic abdominal pain and alternating constipation and diarrhea. He notes his symptoms associated with bloating and sensation of incomplete evacuation. He denies rectal bleeding or weight loss. Physical examination reveals mild abdominal tenderness. Which diagnostic test is most appropriate at this time? A, fecal lactoferrin. B, complete blood count. C, antibody testing for cytolethal distending toxin B. D, abdominal radiograph. E, no further testing is necessary. Let's go. Doctors, by this time, you are pulling everything together. We are summarizing everything we have done. So we are going. And the answer is B. The answer is B. Remember, his symptoms are associated with bloating and sensation of incomplete voiding. He denies any rectal bleeding or weight loss. Physical exam reveals mild abdominal tenderness. Remember this. There's some abdominal tenderness. Which diagnostic test is most appropriate? Which diagnostic test? Remember, abdominal tenderness. Please, doctors, remember, this patient has abdominal tenderness when you palpate. When you palpate, right? So what will you do? Abdominal tenderness. What are some diagnoses which may come into your mind? You're going to think about, can this patient have appendicitis, right? These are all things you want to think about. So you may want to do your CBC, which is part of the initial evaluation of IBS to rule out iron deficiency anemia, which may indicate an alternative diagnosis. So E is incorrect because I see that a lot of you are going for E. Minimal testing is necessary to exclude organic diseases before confirming the diagnosis of irritable bowel syndrome. Remember that we don't have any specific test for irritable bowel syndrome, but any test we do, it is to rule out other things. And especially in this patient who has abdominal tenderness, you want to be very careful, right? No, oh yeah, it's irritable bowel syndrome. Therefore, let me go for E. I understand those who went for the E, but remember, this patient had tenderness. You want to check, is a white cell count elevated, right? If white cell count is elevated in a patient with abdominal tenderness, abdominal pain, white cell count elevated, then you want to go ahead and do some investigations again, all right? Next question. 50-year-old woman presents with new onset abdominal pain and diarrhea over the past 4 months. She reports progressive symptoms with nocturnal diarrhea and unintentional weight loss of 8 kilograms. Laboratory testing reveals a hemoglobin level of 10 grams per deciliter and fecal calprotectin level of 75 micrograms per gram. What's the most appropriate next step? A, diagnose irritable bowel syndrome based on clinical criteria. B, start a low FODMAP diet. C, perform colonoscopy with biopsy. D, test for celiac disease. And E, reassess after 3 months of symptom monitoring. What is your answer? And I can see a lot of doctors are going for C. A lot of them are going for C, and C is the correct answer. So, perform a colonoscopy with biopsy. This patient has alarm features, including weight loss, nocturnal diarrhea, and anemia, necessitating further evaluation for organic disease, right? A colonoscopy with biopsy is essential to rule out inflammatory bowel disease or other structural causes. So, doctors, this one is straightforward. C is the correct answer, right? Next question. Are you tracking with me? You have a 29-year-old man who reports cramping abdominal pain and loose stools that have occurred every morning for the past year. His physical exam is normal and stool studies for ova and parasites are negative. He denies weight loss, rectal bleeding, or fever. His fecal calprotectin and C-reactive protein levels are within normal limits. What feature in this patient's history would make a diagnosis of IBS less likely? Less likely. less likely. A, alternating diarrhea and constipation. B, mucus in the stools. C, nocturnal diarrhea. D, bloating and flatulence. E, improvement in symptoms after defecation. Now we are tying everything together, everything we've learned. We are tying it together with questions and answers. And the correct answer, everyone is going for C. C, the correct answer is C. Nocturnal diarrhea makes irritable bowel syndrome less likely. We learned that alternating diarrhea and constipation is a common feature. Mucus in the stools happens in about 50% of the people. Bloating and flatulence can happen. Symptom is relieved after defecation, can happen. At times, symptom can also be worsened after defecation. But nocturnal diarrhea, no. Next question. 36-year-old woman presents with chronic constipation and a sensation of incomplete evacuation. She has a history of long-term laxative use with minimal improvements in symptoms. Physical examination is unremarkable, and a rectal exam reveals no abnormalities. Abdominal radiograph shows stool accumulation. What's the next best step in her management? A, colonoscopy to exclude structural abnormalities. B, start low residue diet. C, perform anorectal manometry. D, prescribe stimulant laxatives. And E, test for celiac disease. What is the correct answer? A, B, C, D, or E? Doctors, I've seen some people have been sending some messages. Please, it's getting a lot. So if you want to contact me, my number is going at the base of the screen right now. +1 306 891 5649. +1 306 891 5649. After this class, I'm going to attend to everybody. All right. So, what's the correct answer? The correct answer is A. The patient has dysnergic defecation, which is a common cause of chronic constipation, right? Refractory to medical management. Because let's go back to the question. He has a long-term laxative use. He has a long-term laxative use with minimal improvement in his symptoms, right? Ta-da! That's what gives the answer away. Physical exam is unremarkable and rectal exam reveals no abnormalities. Abdominal radiograph shows stool accumulation. So it looks like this guy has tried laxatives upon laxatives upon laxatives and is not improving. So he has what we call dysnergic defecation, which is a common cause of chronic constipation refractory to medical management, right? Anorectal manometry and balloon expulsion testing are essential to confirm the diagnosis. So Dr. Ibironke was asking, how are you going to remove the stool? That is the answer. Balloon expulsion. Balloon expulsion. Dr. Titilope says, Dr. Titilope, what is causing you to say, what's the concern? Dr. Khadija as well says, what is it? Remember that the question gave you an interesting clue. The patient has a history of long-term laxative use. So to go back and say, I'm going to prescribe stimulant laxatives, he has a long-term laxative use with minimal improvement in the symptoms. So D will not help him. Why are you testing for celiac? Not necessary. Start a low residue diet. Not necessary. Colonoscopy to exclude structural abnormalities. Well, but first you want to do your anorectal manometry. Why is it that this guy has been giving stool softness upon stool softness upon stool softness, but is still developing a lot of constipation? That is where the problem is. So now, let's do another deep dive. Please, doctors, are you tired? If you're tired, we can pause the class right now, and then we can continue later. Should we pause? Should we pause? Please, I want to know. Should we pause? Are you tired? Hello? Are you tired, doctors? Are you tired? Okay. Dr. Chizoba and Dr. Sabine says no. Okay. So let's go. Why do you have to do history and physical in a patient with IBS? You want to identify the IBS symptoms, number one, and you want to rule out organic diseases, other diseases which will present with similar symptoms. So these are the things you want to do. So we've already talked about the chronic abdominal pain with alternative bowel habits. So you want to get that from the history, right? Is there diarrhea? Is there constipation? Is it mixed? Number two, you also want to check for medication review. Why is the patient having these symptoms? Has the patient had any recent antibiotic use? Right? Has there been any recent antibiotic use? Has there been any laxative use? That is why he's having the diarrhea. You want to also check for infections like viral and bacterial gastroenteritis, right? You want to ask about family history to rule out other sinister stuff. Family history of inflammatory bowel disease, family history of colorectal cancer, family history of celiac disease. Because if the patient has a family history of these, you want to rule these things out before you just say that this patient has irritable bowel syndrome, right? Now, in the history, there's also something the MCC objective said. Oh, Dr. Khadija said she's tired. She said we should stop. Dr. Khadija, are you serious? Because she said yes, but she's laughing. Are you tired, Dr. Khadija? Are you tired? If you're tired, let me know. Okay, good. So one other thing you want to learn whenever you are dealing with any MCC objective is alarm features. Alarm features. So you have to know if you are dealing with headache, alarm features of headache. If you are dealing with abdominal pain, alarm features of abdominal pain. If you are dealing with leg pain, alarm features. If whatever it is you are learning, eye pain, alarm features, right? So alarm features of irritable bowel syndrome that you need to know on history. If the patient's symptoms started after 50 years, trouble. If there's rectal bleeding, trouble. Nocturnal diarrhea, alarm feature. Progressive abdominal pain. So the abdominal pain the patient is having now is way different from the pain she had, some time ago. Trouble, right? Unexplained weight loss. Something bad is happening, right? If there are laboratory abnormalities like iron deficiency anemia, elevated C-reactive protein, fetal calprotectin, fetal lactoferrin, trouble. Is there a family history of inflammatory bowel disease or colorectal cancer? Trouble, right? If you see any of those, trouble. Now, physical exam usually is normal. If you are doing your physical exam, they may have some mild abdominal tenderness. But in a patient with abdominal pain with tenderness, please don't just run off and say that, oh, this is irritable bowel syndrome. You want to do some further investigation, like what we said, CBC. If white cell count is elevated, then you want to, do further evaluation. Is there some appendicitis going on, right? Then you want to do rectal exam, especially the patient has constipation. And one reason why you are doing your rectal exam is that this synergic defecation, where the patient will give the typical history of, I've tried several laxatives, it hasn't helped, right? And why do we do laboratory testing? Why did we do CBC in that patient? Why are we going to do further evaluation in other patients? It is not because it helps us to diagnose irritable bowel syndrome. No, because there's no definitive test for irritable bowel syndrome. However, those investigations are done to rule out other diseases, right? They are done to rule out other diseases. So, tests which are purposely done to rule out other diseases: complete blood count, diseases like appendicitis. If the patient has diarrhea, you want to do fetal calprotectin or fetal lactoferrin to rule out inflammatory bowel disease. Okay? And if you are suspecting, a parasitic cause of the diarrhea, you want to do a stool test to check for Giardia lamblia. You want to do a serologic test to test for celiac disease. You want to do a C-reactive protein, to check for, what is going on. If the C-reactive protein is high, chances are that irritable bowel syndrome is is less, right? So the key fact is that if C-reactive protein is less than 0.5 milligram per deciliter, or the calprotectin is less than 40 microgram per gram, then the probability of inflammatory bowel disease is very little. So do your calprotectin and do your C-reactive protein when you're thinking about your inflammatory bowel disease. And so all these tests are being done not because they will help you to diagnose irritable bowel syndrome, but they rule out all these other diagnoses. Then you can frankly say that I've tested everything I need to test, and they all came back negative. You also want to do your colorectal cancer screening, which is age appropriate. So if the patient is above 50, you want to do that, right? And then severe constipation, you want to do your abdominal radiograph to check for stool accumulation. And then for those we are suspecting have this synergic defecation, you want to do your two things, anorectal manometry and balloon expulsion therapy. Right? So if you do these and the patient is positive on them, then you have to think that, oh, this patient has this synergic defecation. And this patient might have tried other stool softness and the rest, and they have not helped. Okay, so alarm features, again, because for me it's very important, right? If you're preparing for QE1, no matter the topic, alarm features must feature. Alarm features must feature. Alarm features must feature, right? So indicators of possible organic diseases rather than irritable bowel syndrome. So if you see weight loss, think about something different. If you see blood in the stools, think about something different. And when you see the alarm features, that means that you need to do additional testing. I've already talked about it. Age more than 50 years at symptom onset, rectal bleeding, melena stools, nocturnal diarrhea, right? Progressive abdominal pain, unexplained weight loss, iron deficiency anemia, or elevated markers like C-reactive protein, calprotectin, right? Family history of irritable inflammatory bowel disease and colorectal cancer. So what's the guiding principle here? Select imaging or endoscopic tests based on clinical presentation. Abdominal pain features with red flag symptoms, that's what should guide you to say that I'm going to do these investigations. So, management, doctors, management. If the patient has no alarm features and all the features are similar to irritable bowel syndrome, then no additional testing is needed beyond the initial evaluation. Because if there are no alarm features, it rules out 95% of the cases. If the patient has alarm features, then you do your endoscopy where you can do your colonoscopy for plus biopsies for diarrhea to check for inflammatory bowel disease or microscopic colitis. And you can do your imaging like abdominal CT or pelvic ultrasound for structural lesions or new onset symptoms, right? So if there are no alarm features, most of the time, you don't want to continue. If there are alarm features, then you want to do your endoscopy. If you have a postmenopausal woman with recent onset of pain, bloating, early satiety, and constipation, doctors, please do your pelvic ultrasound, your pelvic imaging, pelvic ultrasound or pelvic CT scan to rule out other pelvic pathologies, especially ovarian cancer. Postmenopausal female, new onset of pain, abdominal pain and pelvic pain, bloating, early satiety, and constipation. Do your pelvic imaging, right? Or abdominal CT scan to rule out structural and pelvic pathologies. So, what's your take-home point today? Number one, remember that IBS, irritable bowel syndrome, rarely causes rectal bleeding, rarely causes unexplained weight loss, rarely causes nocturnal diarrhea. Doctors, thank you very much for participating in the class today. Thank you very much for participating in the class today. It was awesome. So what's the difference between IBD and IBS? Let me go back. What's the difference between IBD? IBD is inflammatory bowel disease. That's Crohn's disease, ulcerative colitis, and IBS is irritable bowel syndrome, right? So doctors, the testimonials keep coming. And you know what? I always tell you, I'm here to serve you. My team and I are here to serve you, right? So I pass the Q1 by God's grace. I'd like to express my heartfelt gratitude to you and the MedCognito team for the excellent course and support you provided. So doctors, let's continue. Remember, you can get access to everything in MedCognito for just $2,199 for 6 months. Or if you just want for 1 month. And remember that in 1 month, you're going to do med drills with me. That's 2 classes. You're going to do 8 classes on various topics because we have a class every Sunday and every Thursday. So if you join for 1 month, you're going to get 8 classes plus 2 classes with me, and then plus 4 classes that we do on every Sunday afternoon. So you're thinking about almost 14 classes for just $450, right? And the last time I did the calculation, it's like when you come to MedCognito, you're just paying about $15 an hour. $15 an hour for everything we have. And when you come in, you get access to the mock exams in the portal, you get access to every video we have for you, right? So doctors, listen, you can always take advantage of what we have to offer. We are here to help you. We are here to guide you. Reach out right now. And for those who want to register right now, because I've seen that some people are asking for it, I'm going to send you the link. Remember that you can decide to pay one time, or you can decide to pay it in bets, right? So I'll take you back to the place where you can, and I'm going to drop the link. Okay, and so with the link, what I want to show is this. You can decide to pay it one time, which is $2,199, or you can decide to pay it even in 6 installments, so $420 every month. And I see a lot of doctors taking advantage of that, right? Or you can decide to pay it 3 times, which is $799 a month, and then you still get access for 6 months. Or you can decide to pay it over 2 months, which is $1,150 for 2 months, and you get access to everything in MedCognito for 6 months. Our live sessions, everything. Or you can decide to pay it one time, and you can get it for $2,199. So doctors, it is awesome to always spend time with you. Okay, it is always awesome. So I'm dropping the link because people are asking for it right now. I'm dropping the link right now. Okay, so that because people are asking for the link. Let me see, is this link working at all? Just hold on, because people are asking for it, but I think I've dropped the wrong link. So let me just get to the right link right now, and you can decide to do, the 1 month payment, or you can decide to do the 6 month payment. That's all up to you, and we respect that. Okay, sorry, don't use the old that one does not work. Use this new link I'm dropping for you. Use this new link I'm dropping for you. The old link does not work. Okay, and doctors, please remember that you can talk to me right now. You can talk to me, and remember that Medros is coming up on January 20th again. Please, you can text me right now. The class is done. Some people have already started texting me on +1 306 891 5649 +1 306 891 5649 +1 306 891 5649. Okay, so thank you very much. Thank you. God bless you. Enjoy the day. Give hugs to your family, and then let's keep learning to ace the exam. All right, send me a message right now. I'll respond. Send me a message right now. It's been an awesome day. Don't forget to subscribe to the YouTube channel as well. Thank you very much. Have a good day. Bye-bye. Dr. Brony here. Bye-bye.